maybe a little after on that one. We'll get started. On the dot? Okay, perfect. I timed it perfectly. Well, I'm grateful to be here today. My name is Christine. I'm here from the Alzheimer's Association's Massachusetts and New Hampshire chapter. So we cover both two states, Massachusetts and New Hampshire. I've been at the association for about 4.5 years. I was previously working on our 24/7 helpline, which I may reference as we're going through the program as a place that you can go for additional resources or support, and I can speak to that directly. Hello.
Hello.
Hi, welcome. For my experience on that, through that program, and I've recently been, since about May of this year, in the role as regional manager for Greater Boston and Northeastern Massachusetts. And my role is to provide education and programming in the community and connect with Greater Boston and Northeastern Massachusetts. So I'm grateful to be here today. You guys have a great community here. I think, how is the screen looking for everyone? Is this pretty clear, even with this light on?
Yep.
That's good for everyone? Okay. Good? Okay. This projector is very nice. Thank you, Nisha. So also we're a good-sized group, but I certainly want to make sure that you're getting the questions that you have asked and answered. So feel free, if, as we're moving through the content of the presentation today, if something jumps out as a question, raise your hand and we can make sure we get to those. I'll also allow some time at the end, and certainly if you want to talk to me one-on-one afterward, I'm happy to chat. One more housekeeping item. How's my volume? Can everyone hear me okay? All right. If that's getting a little wonky at any point, just give me a more feverish wave. If my volume isn't good, here, and this will mean a question. Does that work for everyone? Okay, good. All right, great. If other things get wonky too, you come on.
I love that.
So we're here today to haven't used that word or
no.
blast from the past?
I've never heard it. No, but I like it.
Well, now you know.
Yeah,
Good.
yes, I might start using it.
There we go. If there's, you can put that on your evaluation that you picked up something new today, a new word. Great. So we're here today to talk about the basics. We're going to be talking about memory loss, Alzheimer's disease, other forms of dementia. So again, as we move through this program, if you have any questions, let me know. We will be hearing, there's a few videos that are embedded in this presentation so that you'll hear from some experts, people from Alzheimer's disease centers or our home office in Chicago, or people living with the disease or their care partners who may be sharing a little bit, kind of illuminate some of, or expand upon some of the information that we'll be talking about from their own experience. Well, first, Ron jumped right in. So Ron is the director of the Mayo Alzheimer's Disease Research Center, and he's going to start off by sort of framing the idea and the prevalence, knowing that one of the greatest risk factors for Alzheimer's disease is advanced age. So he's going to talk about what that means in terms of the prevalence of the disease and what we're seeing in terms of that increasing in the United States and globally.
In general, we talk about in individuals age 65 and older that people have perhaps an 8 to 10% more risk of developing Alzheimer's disease in their lifetime. But it's clearly age related. So if your family tends to live into their 80s and maybe 90s, your risk is going to go up rather dramatically. On the other hand, if the people in your family tend to die in their 70s, the risk is lower. But it's clearly an age-related phenomenon. And with baby boomers now, those individuals born between the years of 1946 and 1964, moving into their 60s, this is going to exaggerate the number of people eligible, so to speak, for Alzheimer's disease rather dramatically. Some people have indicated that if we do not do something for Alzheimer's disease, meaning delay the onset, slow the progression, ideally we'd like to cure the disease, but even if we have these modulating effects on Alzheimer's disease, it as a single entity will bankrupt the healthcare system as we know it. Because there's so many people in that age who will need services, who will need extra care. That
No
this
one can
will
hear.
bankrupt.
Is that fair to say? Very low. Okay. So the speakers, are connected to my computer, which is connected here, so I'm somewhat limited in terms of stretching, but I'll give a little synopsis. We'll have Ron's photo up here, Dr. Peterson. He appears very wise, I hope, to everyone. So I can share a little bit of what he shared. He's talking about how we know that the population is getting older, and that we also know that one of the greatest risk factors for developing Alzheimer's disease is increased age. And so what does that mean for prevalence? We're already seeing that we know right now about 5.7 million Americans have Alzheimer's disease, which is the most common form of dementia. About 130,000 residents in Massachusetts. We also know that that number is likely underreported. About 50% of people that have a diagnosis of Alzheimer's disease don't know that they do. It's not being communicated as well within the medical system. And also people aren't necessarily seeking and receiving a diagnosis. So we imagine that those numbers may be greater. Add to that an increased or growing population of older adults, and we can see how that prevalence will increase over time in terms of what we're seeing, the number of people with a diagnosis of Alzheimer's disease or another form of dementia. And he's also talking about in this in terms of impact, the importance of research and what research is looking at in terms of prevalence. So not prevalence, excuse me, prevention, so preventing the disease from happening, but also really important research that's happening in terms of modifying the course of the disease. So can they slow it down or stop it once it starts, in addition to hopefully someday coming up with some treatments that prevent the disease from happening in the first place. So that's just sort of laying a little bit of the foundation about why it's important to talk about what Alzheimer's disease and other forms of dementia are, and have a sense of what's going on, knowing that more and more people may be diagnosed with this disease as we're seeing the population age as well.
So what percentage?
Sure.
Is it
In terms percentage,
in Massachusetts have Alzheimer's or
yeah, that's a
dementia?
good question. We know about, I'm trying to think of what the population in Massachusetts is. That's a good question. I know from the data about 130,000 people have the diagnosis. Again, likely underreported.
Yes.
Anyone off the top of their head know the population in Massachusetts?
No.
It's a great question in terms of what the percentage is. I'll reference, as I mentioned it before, and we'll reference it again, our 24/7 helpline is a great resource for specific questions like that, or things that if I might touch upon, but you want to expand upon, or I might reference. My colleagues that are on the helpline have access to all sorts of census data, new research that's come out, does coconut oil cure or cause Alzheimer's disease, anything you might read in the paper. My colleagues can answer some of those questions in more detail if I don't know the answer, like that great question today. Any other questions so far? Okay.
In general,
I want to go there. So what we want to talk about, one of the things that I like to start off talking about is what are some typical changes or age-related changes related to memory and thinking that may be related to age versus related to Alzheimer's disease or another form of dementia. We know that as we age, the body begins to slow down or change in some ways. There's some change in muscle tone, some response or reaction time in the body. We know there are physical changes that are accompanying aging. Similarly, we see some changes that are expected with the memory, with the mind as well. Not just the memory, with thinking, processing time. There are some normal age-related changes that we see that are typical. You'll see a few of them up here. I think what's important to highlight is you'll see in a few of these examples, making a bad decision once in a while, losing things from time to time. The distinction there is that there are incidences where this is happening not across the board or not globally. So from time to time, or there are situations where you might see a change in your memory or thinking, but it's not in every area of your life, for example. Another common question is about misplacing keys or misplacing an item in the home. And what may be related to a more age-related change might be that you're not sure where it is, but you can kind of retrace your steps, or maybe 10 minutes later it's like, oh, aha, the keys are there, that other place that I put them. When someone has a diagnosis of Alzheimer's disease or dementia, or it's starting to tip over to something that you might want to look into a bit more, you're starting to see that ability to retrace those steps is not there anymore, or it's impaired to the extent that it's harder to retrace those steps to refine where the keys are. You might start relying on more cues or props around the home, other things to kind of guide you to where the keys may be, versus your memory at some point being able to recall that. Does that make some sense? Okay. Those are a few examples. I think it's important also to highlight up here the bad, questionable, maybe not bad, maybe questionable decision making, forgetting which word to use. I think a lot of times when we're thinking about Alzheimer's disease or other forms of dementia, like I use the word wonky. I don't know if I typically use that word, but that's what came out. We oftentimes think about short-term memory changes, and there are oftentimes other symptoms that may be associated with something going on that may be related to Alzheimer's disease, another form of dementia, or maybe worth just getting a more formal diagnosis and seeing what is going on that's causing these symptoms. It's not just memory related. So changes in judgment or thinking. Sometimes it's hard to recognize that in our own selves, but those around us may be questioning how decisions are being made, or maybe bill paying or other daily routine or normal routine situations are becoming a bit more difficult or aren't being followed through with in the same way, might prompt some discussion about, is there a problem solving challenge? Is something like paying the bills that you've always done starting to become a little bit more difficult? And again, it's a one-time thing. Is there a lot of other variables that are at play, like attention, distraction, or are you seeing this consistently over time? We'll talk a little bit about what that consistency might mean, but I think there's a little bit of that distinction there. We don't want to just think about memory. It's important, of course, but there are other things that our brain are doing in terms of our thinking that we want to be on the lookout for, too. Does that make sense?
Yeah.
Okay. Great. So I may skip what Joyce has to say since you won't be able to hear her, but I can give a little synopsis of what Joyce is sharing. She has a diagnosis of Alzheimer's disease, and she's sharing a little bit about the distinction there, that there were things she started to notice in herself that were falling sort of beyond this category that was just up there about normal age-related changes that you might see. We'll see on this next page here some changes that may be problematic. And she's highlighting that she was starting to see some confusion or changes in her memory that were starting to impact her daily life. So she was recognizing that the changes in her short-term memory were consistent. So it wasn't just related to maybe a missed appointment. It may be missing numerous appointments or numerous obligations that are on the calendar, starting to see things with a bit more consistency. And that prompted her to look into and see, is there something more that's going on? She noted in the synopsis that she gives about her story that she went to the doctor upon initially noticing what was going on, and they said that everything seemed okay, but she started to continue to see the symptoms that she was noticing progress or get a bit worse or more troublesome to her. So she went back again, she followed up and advocated for herself, and at that point it was found that they were able to do a bit more of a thorough diagnostic evaluation in combination with more symptoms that she was seeing, and she eventually received a diagnosis of Alzheimer's disease. So there's this consistency piece, and then I think there's that follow-up piece too. It's really important to start and reach out and advocate if you're noticing some changes, and then stay on it too. If you're noticing those things progress or change, you want to continue to follow up with your doctor about that as well. That's a little bit about Joyce's story, taking not verbatim, but synopsis of what she shared. And up here you'll see that there are some changes as well as on your slide that we know the 10 changes up here are associated with what we talk about the Alzheimer's Association are some of the 10 warning signs. So some of these changes in one of them or in isolation, or even a few of them, it doesn't necessarily mean that you have Alzheimer's disease or another form of dementia, but it may mean that something's going on that warrants a bit more of an evaluation or a conversation with the doctor to find out what's going on underneath this that's causing these symptoms to happen or these symptoms to change. We'll talk a little bit more about what some of those disease processes are or medical conditions that can cause some of these symptoms. But if you're noticing any of these changes, it's important to consult with your doctor. See about having a conversation with maybe your internist or primary care doctor to start. We'll talk a bit later on about what that diagnostic process looks like. But if you're seeing some of these changes, these are some of the signs that we as an organization, in collaboration with medical providers, have kind of come up with to say, these are some of the things that might be that tipping point. Tipping over from the normal age-related changes in your memory and thinking to something that might be a bit more problematic. I think one of the kind of keys or hallmark pieces to consider in whatever the symptom is it disrupting your daily life? So your ability to function. Are the symptoms that you're seeing, whether it be a change in your short-term memory or a challenge processing information, maybe new problems speaking, so having trouble finding words or getting words out, is that starting to become troublesome enough that it's making it difficult for you to function in your day-to-day life? That's that tipping point that when we talk about what is dementia, in terms of it being diagnosable or to fit the criteria for that, the big change is that it's impacting your function. So you might have some of these symptoms, but they're mild, they're occasional, and it's not making it difficult for you to function day to day. The functional part is that tipping point over to what we might talk about with Alzheimer's disease or other forms of dementia. Is everyone following that okay? Does that make some sense?
Mm-hmm.
Any questions so far? Okay.
I've got one.
Sure, of course.
6.84 million
Okay.
Massachusetts.
6.84 million and 130,000 diagnosed.
Yeah.
My background's in social work. I did that for a reason. Math's not my strong suit.
No.
So we can see there, it's a increasing prevalence and a significant one. I mean, 130,000 people is a lot, again, especially when we're thinking about the potential for that number to be underreported and other things like that. 130, you could say, yeah. You get your math skills on, you let us know what you come up with. Phones are good. I remember my teacher saying you'll never have a calculator with you all the time, but now we kind of do sometimes if you have a smartphone.
It's 2%.
2%, thank you. You didn't need a calculator. There we go, thank you very much. Appreciate that. 2%. Great. Collective knowledge is important. Thank you. So when we're talking about Alzheimer's disease, memory loss, dementia, it's an important piece, I think, to pause here to talk about what's the difference between Alzheimer's disease and dementia. Anyone know the difference, or has anyone heard those words used interchangeably? Shout out. Yeah?
My brother-in-law has been diagnosed with dementia.
Okay.
I wasn't sure about the difference.
Okay.
That's one of the reasons I'm here.
One of the reasons you're here. Well, I'm glad you're here.
Yes.
Okay. Has anyone else ever heard those words maybe used interchangeably? Perhaps, okay.
Dementia's like a Frontal Lobe. You can have vascular, you can have different, like maybe,
Anybody, you got it?
there's different types.
Great.
Alzheimer's.
Yeah.
I have really long sense, I really don't know. For someone who has it, I don't know at all.
You're right on. The umbrella term is exactly not only what I would say, but you'll see here this beautiful graphic looks like an umbrella. You're right on. So when we talk about Alzheimer's disease, and I'll just share what, do you mind sharing your name? Trisha shared that dementia is an umbrella term. That's a lot of times how we describe it. It's an umbrella term that describes a number of different symptoms that are associated with memory and thinking. There's a number of diseases that cause symptoms of dementia. So Alzheimer's disease is a form of dementia. The other forms of dementia up here, or other diseases, are forms of dementia. But dementia itself is describing symptoms. It's not a disease process. Sometimes people receive a diagnosis of dementia because they may not be sure what the underlying disease process is that's causing those symptoms. They've come a long way in terms of diagnosing what form or what is causing the dementia, but there's still sometimes that they're either working on that diagnosis or have a probable diagnosis but might be calling it dementia because they're not definitive about what disease process is causing the symptoms that you're seeing. Question? I see your face.
I'm
Yep.
looking at that vascular dementia.
Yeah.
Way up, in what?
Yep, vascular. Yep.
No, I know that.
Yep. What does that mean?
Yeah.
Sure. So vascular dementia is used to describe when there are changes in the brain due to either a large or small strokes, or vascular changes can cause some changes in the brain as well. So there may be some obstructed blood flow to certain parts of the brain. That's what we would call vascular dementia.
Oh, okay.
Yep.
Yeah.
Having vascular disease doesn't mean that you have vascular dementia. Yeah. Doesn't mean that you have vascular dementia.
Okay, good.
But there is some increase. It's okay. That's a good question. Vascular dementia alone accounts for a small percentage of forms of dementia, so about 10%. But we do often see it in combination with Alzheimer's disease. So oftentimes people may have Alzheimer's disease and vascular dementia. They might call that mixed dementia, but both going on at the same time. And the challenge is too that sometimes there is a major stroke that can cause one incident that can cause changes in the brain, but sometimes there are smaller strokes that people may be experiencing and not have symptoms of, and over time that can cause some changes in the brain that can cause issues with memory and thinking, may cause some symptoms of dementia. Any questions? We're going to keep going through this, but any questions about that so far? So I'm going to go back a bit just to what is dementia. And again, here's this interferes with daily functioning, so that's that tipping point, if you will. And it's describing changes in cognition, which encompasses a number of things. Not just memory, but certainly memory, language, maybe expressive, or the ability to understand language. Changes in personality or mood. There are parts of the brain that we'll talk a little bit more about that impact our personality, have an impact on our inhibitions or lack thereof, and those may be signs of a form of dementia as well. Again, not just the memory and thinking, although that is an important piece too. There are some reversible diseases that can mimic dementia in terms of mimicking or showing symptoms of dementia. And we say reversible because the medical conditions up here can typically be treated. And so if the medical condition is treated, you may see a relief or a change in those symptoms. So for example, oftentimes, brain tumor is a difficult one, right? So if it's a brain tumor that's causing those changes and there's an ability to remove the tumor, you may see a relief of symptoms from that. Not always, I'm not a neurologist, but from my understanding, not always possible to extract a tumor with that level of success. But if you were able to, you would see that change in symptoms. It's not something that's progressing within the brain from another disease. It's due to where that tumor is. We do sometimes see with hypothyroidism or dehydration, infections, other nutritional imbalances, sometimes can mimic or show themselves as symptoms of dementia, having confusion, short-term memory issues, and those may be related to or symptoms of a medical condition like the ones up here. So if you're very dehydrated, sometimes severe dehydration can cause confusion, and so there may be a thought that that's related to Alzheimer's disease, another form of dementia. When you treat the dehydration, those symptoms get better. So it's important to look into, we'll talk a bit more in a little bit about what the diagnostic process looks like, but knowing that there are some conditions that can mimic or make symptoms of Alzheimer's disease or another form of dementia worse or exacerbated, you can see why going to a general practitioner to start can be a great place to get some of these medical diagnoses looked into first. Lab work and other things to see, is there another medical condition that's the cause or contributing to what's going on? Yes, sure.
I have a little story about dehydration.
Okay, sure, yeah, share away.
An elderly friend of mine who was actually older than me,
Yeah.
in her late 80s, who lives just over the bridge. She called me and said she was feeling very bad. Her brain wasn't working well, etc., and she was sure she was getting Alzheimer's.
Sure.
She she needed some help and could I come over.
Mm-hmm.
So I went over the bridge to her house and I took a look at her and I said, Ruthie, when did you last drink anything?
Mm-hmm.
And she said, well, I think I had half, this was late afternoon.
Yeah.
I had half a cup of coffee for breakfast.
That was
but
it.
I haven't been thirsty.
Mm.
And I said, listen, if you remember, I'm saying to her,
Yeah.
there was a lady at our exercise class that
Yep.
we went to who was taken to the hospital from the
The
senior
class.
center.
Mm-hmm.
They found that the only thing wrong with her was dehydration.
Dehydration.
But her
Yep.
brain wasn't working right. So I
Mm-hmm.
said, I'd like to see you
Drink some water.
this whole bottle, like a quart and a half
Yeah.
of water. And I said, I want to see you doing that. She did it. She hated drinking water.
Mhm.
She did it. And almost like 5 minutes later, the clouds started to
She felt
disappear,
better.
and she felt better.
Good.
And her head was clearing up.
That's
It
a
was
great,
like
two good examples of that, yes. So, what's her name?
My name's Valerie.
Valerie. So Valerie just shared, I'm not sure if everyone could hear her, but two great examples of how dehydration can show themselves as having some symptoms of confusion or short-term memory loss. Someone from across the bridge that she went over to see drank water and started immediately feeling a bit better. Similarly, someone else from an exercise class, it turned out that extreme dehydration was the cause of the symptoms as opposed to an underlying disease process like Alzheimer's disease. So thank you for sharing that, Valerie. It illuminates how we see this in real life. It's not just up here on the slides.
It's eye-boggling.
Yeah, very much so. Eye-opening. So everyone, if you have something to drink, take a sip.
I don't. I would like to.
So we'll get back to this slide here that you were so kind to share. The umbrella term was right on. So we'll talk about Alzheimer's disease a little bit more after this. The reason we have its own separate slide is that we know Alzheimer's disease is, again, the most common form. So it accounts for about, it's a big range, but 60 to 80% forms of dementia related to Alzheimer's disease. Vascular dementia and mixed dementia we talked a bit about. Dementia with Lewy bodies, for sure you mentioned as well. That's a form of dementia that's caused by abnormal folds that form in the body called Lewy bodies, in the brain. And we typically see symptoms related to Lewy body that can show themselves in signs of really vivid hallucinations or challenges with wakefulness. So sometimes people will lose attention or almost seem as though they're passing out, and it's really maybe more related to this form of dementia. There's also some mobility challenges associated with Lewy body dementia, shuffled gait, and some stiffness in motor movement. So we see some of those symptoms related to Lewy body. And frontotemporal lobar degeneration, sometimes called FTD, that's describing the frontal lobe, which is the area of the brain where we see individuals with this form of dementia see the most, have the most significant, is the part of the brain that's the most significantly impacted by this disease. And that's the part of the brain that we know is associated with some judgment, inhibitions. So when you may see changes in personality or extreme decision-making changes, it may be that the frontal lobe is impacted, may be an indication that it's this form of dementia. We typically see as well a challenging component of FTD is that it often will, people with this diagnosis may be a bit younger than with other forms of dementia. 65, a lot more people have FTD or may be diagnosed with that. Yes?
Lewy body, isn't that very bad to have a Lewy body?
It can be really challenging, yes. It's a difficult disease, for sure.
Can they diagnose that easily?
Well, we'll talk a little bit about what that diagnostic process looks like, but it's a great question. Can they diagnose that easily? A lot of times to get at really seeing what the abnormal protein is that's in the brain, it requires a bit more of a brain scan to see where are the changes, what kind of abnormalities are they seeing. A lot of times too, we'll talk about this, but there's other ways of performing the diagnostic evaluation by seeing the presentation. So again, some of these symptoms are a bit more pronounced with Lewy body that you wouldn't necessarily see as pronounced in other forms of dementia, like the mobility challenges and the hallucinations. But usually a combination of things in the process can get at a probable diagnosis. But it's challenging because there's the changes in memory and thinking, for sure, which are challenging in and of themselves, and then the additional safety challenges sometimes too of the mobility challenges, potentially from falling and other things like that.
I thought you couldn't diagnose Alzheimer's unless it was after they
Autopsy,
died.
sure.
An autopsy, right?
Yep, so we'll get back to that one. I'm gonna hold that one, Valerie. We're gonna talk about the diagnostic evaluation process and how that process has improved over time. There was a question about, can you only diagnose Alzheimer's disease definitively on an autopsy? And that used to be sort of and there are some physicians and some doctors that are still in that camp, and others that feel like we've come such a long way in terms of the diagnostic technology that we can get very close to a definitive diagnosis. So we'll talk about that a little bit more. It's a really good question. There are a number of other forms of dementia as well. These are just a few. There are many. So there are many disease processes that can cause symptoms of dementia. There's a few up here as well. Parkinson's disease, we know, is a disease that can also have impact changes in memory and thinking. Normal pressure hydrocephalus. There's also a syndrome that can be associated with prolonged or chronic excessive alcohol use that can cause changes in the brain. And those are disease processes as well that can cause changes in the brain and therefore changes in memory and thinking. A number of other forms of dementia as well. These are just a few up here.
What is that first one?
So CJD is typically what it's called. It's a rare form of dementia, very rare form. And they've seen that there have been some changes in some of the properties in the brain and the way that the nerve cells are communicating. Sometimes they've seen it associated with mad cow disease. I don't know if anyone's heard about that. There's been a link between that and this form of dementia. It's very rare, so a lot of the research in terms of what's causing it or where that connection is it's hard to come by because there's not as many people with the diagnosis to find out why.
Where was that discovered? Because the name is so foreign.
It's a good question. I'm not sure the answer to that, where it was discovered.
Yeah.
And I imagine it may have been either one person with a hyphenated name or two people.
Yeah.
Yeah, that's a good question.
I know it.
Yeah.
Never heard of it.
Yes.
When you give blood, they'll ask you, I don't remember how it's pronounced.
Sure.
If you have that disease, you're not allowed to give
Yeah.
blood.
Wernicke-Korsakoff?
The
Seen
first
that.
one.
Oh, the first one, okay. So it may be that
Yeah.
sort of
I've seen that all the time.
concern of,
That name, Creutzfeldt, Jacob.
like with mad cow disease, the trying to think of it, the infectious component to it. Yes. Thank you. Thank you.
The Creutzfeldt that's not the one that just picks Jewish people, is it?
Not to my knowledge. Not to my knowledge.
Valerie, what did you just ask?
Valerie asked if there's, with this disease, more prominence in people that are Jewish.
That's what I thought.
Yeah, descent. Not to my knowledge.
There's some disease it is, and it wasn't Jewish one.
I'm not sure.
Question,
So the other component that's important to speak about is mild cognitive impairment. Has anyone heard about that? MCI, mild cognitive impairment.
Yeah.
So there may be changes or symptoms that people are experiencing that would show up on testing. So if you had if you were noticing some changes, other people might have noticed it, but wasn't impacting your functioning, so it might not reach that criteria for dementia, but you're having some mild symptoms, and you receive testing, and either from a brain scan or a neuropsychological exam, which we'll talk about, there were some flags that noted that there were some changes, but it wasn't significant enough to impact your daily life. They might call that mild cognitive impairment. Sometimes that plateaus, and other times that progresses and develops into Alzheimer's disease or another form of dementia. What's interesting about mild cognitive impairment, and you'll see here it says increases the risk of developing the disease. Research is now looking at, with more advancements in technology and being able to see brain scans, they're seeing that there are changes in the brain that may happen up to 20 years before you see symptoms. So we're starting to see some scientists are looking at Alzheimer's disease sort of as a continuum. So you may have changes in the brain with no symptoms, and then at some point have some symptoms. They don't impact your daily life, but you might call that mild cognitive impairment, that then continues to progress and develop until the symptoms are pronounced enough that they sort of meet that criteria to be described as Alzheimer's disease. It's a growing body of research in terms of being able to study people earlier and earlier on and look at changes in the brain without symptoms to see what is this continuum looking like, and are there intervention models that we can put in there before symptoms happen. We won't be able to hear what Steve says as well, but he talks about how he received a diagnosis of Alzheimer's disease. Is the most common form of dementia, as we've been talking about. But he just shares his story a little bit about how he started noticing symptoms somewhat similarly to Joyce, who we didn't hear from before, but I gave a synopsis for, starting to see some changes that impacted her daily life. So we've talked a little bit about Alzheimer's disease as we've been talking about forms of dementia. We do know that Alzheimer's disease, as I said, is the most common form of dementia. Affects over 5 million Americans, so this slide is slightly out of date. We know from our 2018 facts and figures it's about 5.7 million. And it's a disease that progresses, so the symptoms become more pronounced over time. There are some forms of dementia, again, those ones that might be reversible, or maybe if you have a stroke or something that impacts one area of the brain that's not progressing, it might plateau. That's different from with Alzheimer's disease. We know that the symptoms progress. It's important to think about how the brain works in the context of Alzheimer's disease, but I would say with other forms of dementia as well. We know that there are over 100 billion nerve cells in our brain, so they're neurons, and this is our brain's way of communicating. They've been able to identify that some of the changes related to Alzheimer's disease that they're seeing in the brain are related to some abnormal protein buildup called plaques and tangles. Has anyone heard of that before? A few people, a few head nods. So the plaques are what form in between the nerve cells, and the tangles are within the nerve cell body. And those abnormal proteins that build up cause the communication between cells, or the communication through cells, to become impaired. And over time, if that communication continues to be blocked or to not happen, the nerve cells can begin to wither. And that's where we start to see some areas of the brain where there are symptoms with memory. So if the hippocampus is one area where those nerve cells are having trouble communicating and there's some nerve loss there, you start to see that that's an area where the symptoms are, where you start to see symptoms or changes in memory. This next slide gets at that a little bit more. So we'll see here that there are a number of different areas of the brain that impact, that control certain areas of our functioning. We know that in the hippocampus is a major area for our memory and our language. And that's one of the areas where we see a lot of the cell death in Alzheimer's disease, which makes sense when we know that that's one of the hallmark or more prominent symptoms of the disease. Similarly, we talked a little bit more before about FTD. That's the frontal lobe where that judgment and reasoning is taking place. So there are areas of the brain that are associated with some of the symptoms that we see. And that may, when we're talking about diagnostic process, that's where the symptoms that we're seeing give the doctor some indication about where maybe some of the changes are going on in the brain, and that can help make a diagnosis, in addition to a few other things we'll talk about too. I think it's very important here too to show what happens with Alzheimer's disease in very late stage, just to show the difference between, or where you start to see some of the changes in the brain. Again, we often associate with changes with memory, but ultimately the disease affects all parts of the brain as well. And I think it's really important to highlight this. It's a dramatic image, but it's also really important to note that it's a physical disease. So there are physical changes that are happening in the brain with Alzheimer's, with other forms of dementia as well. And I think I just like to highlight that because I think sometimes it can be challenging to understand that unless you know about the disease, or you're living with the disease, or you have a loved one with the disease, because it's not as apparent to the eye what's going on behind, what's going on in the brain. And I think it's really important just to know that these are physical changes that are happening. We all have it's a normal human reaction to have maybe a sense of denial, or limited insight into what might be going on and sort of projecting off. But it's really important to recognize that with this disease, some symptoms that you may see are due to these physical changes in the brain. There may not be within someone's control if they need a bit more help in prompting questions. So I think it's really important just to highlight.
Does this all have to do with genes?
There's some genetic,
You have people like a 90 or 100 and they're sharp as a tack.
yep, yeah.
Yeah.
It's a very good point. So there are a number of risk factors. I said age is the biggest one, but it's not deterministic. And there are some genes that they've identified that increase your risk. But the genes that are deterministic, meaning if you have this gene, you will get Alzheimer's disease, are very, very rare. It's a very small percentage of people that have that form of dementia. And people that do know it. Usually the onset is much younger, and it's within or very pronounced in a family. There's a research study that's going on with a family in Chile, and it's almost across the whole board that most people within the family have the disease, develop it at a younger age, even in their 40s. So that deterministic gene is very rare.
And they've had it in those families for generations.
Had it in the families for generations,
Yeah.
correct. But there are some genes that increase your risk, just like increased age, just like some of the other risk factors that we do know can account for increased risk of developing the disease. But you're right, there are some people in very advanced age that do not have any changes in their memory and thinking. Just like there are some people with very advanced age that have no blood pressure issues or no cardiac issues, no other medical conditions either. So it's true. There are
You're
people.
kind of doomed since you come to Earth.
Well,
Because
as
what's
we
the outcome?
age, right, knowing that that's one of the bigger risk factors, I hear what you're saying, knowing that's a risk factor, as you get older, there is an increased risk with other medical conditions too, yeah. Yes,
Doesn't diet have a lot to play in Alzheimer's?
yeah, great question. So the question was, does diet have a lot to play with Alzheimer's? And there's a lot of research that's looking at that now as well. We also have a program, it's called Healthy Living for Your Brain and Body. And I can share with you, I think I have our e-learning page there. It has links to our free e-learning workshops that you can dive into that one a little bit more. But what I can say is that there's research now that's looking at things like the Mediterranean diet, other lifestyle factors too, like exercise, social engagement, cognitive activity. So you're covering at least 2 of those bases today, right? I hope you're learning something new. Your brain is being stimulated, cognitively active in this conversation, and you're engaging with other people. And those have been found to be protective factors for reducing the risk of cognitive decline and for improving symptoms if someone is living with Alzheimer's disease or other forms of dementia as well. More research to be done on those lifestyle factors. It's sort of what they're calling them in the research, but there's a lot of compelling research there that's looking at just that. One study was done in Finland that looked at those 4 components: diet, exercise, social engagement, and cognitive activity, and it was very encouraging. And now they're trying to replicate that here in the United States to see if we're seeing that again. We can speak to that a little bit more firmly. But there are lifestyle factors like that that can help contribute, lessen the risk. And one of my favorite things about the diet research is that there's a dose effect to it. So the more compliant you are with something like a Mediterranean diet is one of the ones they study. The more compliant that you are, the more your risk is reduced. But even if you're somewhat compliant, your risk is reduced. So I think that's encouraging. Being 100% compliant with a diet or any lifestyle modification can be challenging, but to know that there's still some positive effect of even being somewhat compliant, I think is encouraging for most of us. Maybe I'm just speaking for myself, who being 100% compliant can be really, really challenging to sustain that over time. Yes.
There was a woman from the Alzheimer's Association.
Sure.
I just remember her middle name was Innocent, she's Italian, and she gave us a talk.
Wish I knew her.
And I'm telling you, she had the cafeteria there, or whatever you wanna call it.
Sure.
Prepare a 4-course meal, and it was wonderful.
Was it good?
And it was really healthy.
That's
She says that
wonderful.
it can really change the outcome of Alzheimer's by your diet.
Yeah. Well, I'm sure, and you just shared that there was it at do you know what was
It
this?
Nichols Village.
Nichols Village, okay, yep. So she was just sharing that they presented a meal. I think that's great. We should
That is
always
so
pair
nice.
our healthy living program with a healthy meal. I think food draws me places, so that wouldn't hurt. And then also demonstrate what we're talking about. Less processed food, healthy fats, berries, those sort of things that maybe historically we kind of know might be healthy in terms of our diets, but are a little bit more challenging to implement with regularity.
Don't forget wine.
Wine. There's research on wine as well, somewhat more related to vascular disease. But yes, That's an area of research too. I don't know if there's any research studies looking for participants in that area, but. So we talked a little bit here about risk factors, age being one of the primary risk factors. We also know that the incidence is higher in women, and there's some, it's being looked into more in terms of their other factors, but one really big contributing factor is that we know that women tend to live longer. And so there's that higher risk as you age, so we know that with women living longer, there's a higher risk there for women. Family history can increase the risk, but again, not deterministic unless there's that really less common, rare deterministic gene at play. And we do know that there's a higher incidence of Alzheimer's disease in individuals with Down syndrome as well. Yeah. Looking at and sort of studying the why behind that, but as individuals with Down syndrome have been aging and living longer, much like the general population is living longer as well, so starting to see a higher incidence of Alzheimer's disease and studying that to find out why that may be there, but there is a high correlation. Yeah.
Like, would they be classified with having Alzheimer's, the people with the Down syndrome, like at an early age? And then they'll find out that it is really.
So it's typically that someone may be diagnosed, may have Down syndrome, and then also receive a diagnosis of Alzheimer's disease. It's typically at an earlier age than if you do not have Down syndrome. Yep, so younger onset.
Wow.
Yep, but two separate diagnoses.
Right.
Yes, yep. Does that answer your question? Yeah. Okay.
Thank you.
Any questions here? Any risk factors you've heard of or considered, concerned about?
I think it's all confusing. I really do.
It's a lot of information.
It is,
I
but
appreciate that.
to know when to go to your doctor if you think it, like me, navigation. Don't turn me around in my car because I won't know where I am at.
Yeah.
But I would not know when to start the visit.
Well, you are just my transition queen. I didn't pay her to do that. That's my question. It was a perfect segue into selecting a doctor. So what we talked about earlier in terms of those some of the 10 warning signs, I think that if you're starting to notice, again, any of those warning signs that are impacting your daily life, really any concern, I think it's important if you're noticing a change to seek out some medical evaluation. It can be very helpful to get a diagnosis early, and there are things that we'll talk about that can be done in terms of intervening, but it can be even more helpful if you know what you're looking at a bit more earlier.
Exactly.
Yeah. Hard to do though. I think
That's
it's more than just saying, I see this, I'm going to the doctor. I think we have to appreciate that that's a challenging thing to do. With any medical condition, particularly one that may be impacting your memory and your thinking. It can be frightening, for sure,
Yeah, so if you go to the doctor and you tell them, like, you know, I forget things, I don't know where I left my keys or whatever, they just say, normal progression, getting older. Everybody measures.
Well, there are some, So one of our goals at the Alzheimer's Association is working on education for physicians and other healthcare providers. There is a new bill that passed recently, just this past, is it July or August, Alzheimer's and Dementia Act, that's really aiming at ensuring that physicians have Alzheimer's disease training as part of ongoing education that they're receiving, because we do know that it's about 50% of people that have a diagnosis don't know they do. That's a big number. And some of it is that it may not be communicated. I don't necessarily think it's a malicious, we diagnosis and we're not telling, but it may be in combination with other medical diagnoses in the hospital or other conditions that are going on, that formal conversation, this is the diagnosis, isn't happening as much as we'd like it to. And I think with that, it perpetuates this idea that it's maybe normal aging, because there hasn't been this training or understanding that if you're seeing these changes impact your daily life, it's not. So I think we have some, and of course, I think I might have them in my bag, some bookmarks that have the 10 warning signs. I encourage people, when I used to work on our helpline, bring that to the doctor. We'll talk a little bit more about some things that you can do to help prepare for a diagnosis, for a diagnostic evaluation. Some of these things we'll talk about I think are important, even if you're going to your general practitioner or your primary care, just to it's a moment in time in the doctor's office, and whatever you can do to flesh that out a bit more, provide more context, I think the better. Go ahead.
May I share?
Of course you should, love
Because
that.
I didn't have any of the symptoms. My doctor found it. She's known me for a long time and noticed different things with me, so she started doing tests without my understanding.
Interesting.
To eliminate everything.
Yeah.
She's a specialist in dementia too, which
Okay.
I didn't know till now. And that's where she found the early onset. And I did not know it. It is shocking, but
Mhm.
she knew what to look for. And, because for me, stumbling over my words is like, you know, you don't think that's something of a serious
Mhm.
nature. But she's because I've known her for 15 years, and she noticed these subtle changes.
Yeah, thank you.
So sometimes the doctor.
Yeah, you can go the other way. You're very
Yeah,
right,
he did
Tricia,
not-
thank
he
you for
did
sharing
not-
that.
Yeah, she did not tell me until she was absolutely certain.
Mm-hmm,
So,
thank you for
I'm
sharing
still
that.
accepting it, but
Thank you
that's
for
okay.
sharing that, thank
I know
you.
Milton, you know Milton?
Oh, I know Milton,
That's the
I
first
do.
person I called.
We work cubes away,
Yeah,
I can see
he was
him
the
from
first
my
person
cube.
I talked to, and I thought I knew him.
I'm so glad you did.
He's a sweetheart.
That's good, he is, Milton, one of my colleagues.
Now
He's
tell
great.
the rest of the story.
I don't know.
Yeah. Her doctor recommended us to go see a neurologist.
Okay,
So we went to see this gentleman,
yeah,
right?
not,
Absolute disaster.
oh, I'm sorry,
You know,
George.
here's a piece of paper, draw a circle, you know. So she's on the other side of the table, so she, I think you said 11 o'clock. So she drew, hand draw, put 11, right? So he's over there saying, well, you know, you're
Like 2
numbers
seconds
just,
off.
just aren't quite lined up.
Oh,
Like,
goodness.
it's not quite at 11, it's, you know, a little past.
Oh, That's like this
So-
clock versus that clock, right? I mean, come on.
No, so, in the end, he asked her a whole bunch of questions to remember
Mhm.
this, and like 5 things, and then he went back, and he says, we really don't depend on the MRIs. Those really don't matter,
Okay,
you know, and as far as he was concerned, if she didn't get lost, right,
If you
in
don't get lost,
places, you don't have it, right, end of story, you know.
And,
and this was a neurologist.
yeah,
Yeah.
and my primary care was ripped. She says, that is not true.
Yeah.
Not all Alzheimer's people get lost.
Yep, it's a very good point. So not everyone with Alzheimer's disease gets lost. It's not the only symptom or the only change that you might see that's associated, for sure. Thank you guys for I think you have such a wealth of knowledge in that story. I think there's a piece of it that you might defer to a specialist, like a neurologist, over your primary care, when in fact, there are situations where they have the wisdom of knowing you for a long time, so they might see more subtle changes or have experience with dementia that maybe you didn't know. Some of it too is, it's feeling comfortable with the doctor. I mean, this situation that you're describing with the neurologist goes beyond, I think, feeling comfortable, but there has to be this rapport and trust in what the process is looking like, the information that they're sharing with you. So it's really important and I think essential to know that if you go to a doctor that is not a good fit for a number of reasons, it's okay to go back to your primary care, go back to another neurologist. It doesn't mean that the whole process is not worth pursuing because one provider is not as helpful. Nice way to put it.
Could I add something to that?
Sure, Valerie.
But I think one of the problems is,
Yes.
once you meet somebody like that who's supposed to be an expert, and they sort of put you down somewhat, it's very deflating for a
To go back,
patient.
yeah.
And it takes a lot of courage for people to take that
For
step
sure.
to begin with.
Yep.
And then it's on them, the onus is on them to go back to their primary care.
Mhm.
Tell them the horrible story.
Yeah.
And start all over again.
Right.
It's asking an awful
It's
lot.
asking a lot. I hear you.
Yeah.
Yep. So Valerie was just sharing, which is true. I mean, it takes courage and it's hard. I mean, it can be challenging to go take that step to go share these concerns with your primary care, additionally go to a specialist, and then to have to go back and go to someone else. And sometimes if you're hearing from a neurologist, okay, everything's fine, you might say, oh, okay, and not pursue a further diagnosis or
Because
further
you
evaluation
think that's the end of
as
it, yeah.
well. Yeah, so I think there's a lot to that. It's again, not as simple as, I know I'm seeing these changes, I'm taking that next step. This is not as linear often as that. And just another sort of plug, if you will, for the helpline, and my colleague Milton just shared, we're happy to be a resource to provide some feedback about diagnostic clinics that might be in your area, other neurologists, further discussing what selecting a doctor looks like or what the diagnostic process looks like for your individualized situation that might be more specific to you than this sort of, hopefully a little bit of a general overview today to give you a sense of things and expand maybe your thinking about this. But we can dive into that in much more detail with you one-on-one on our helpline or talking with one of our care consultants. So all really important points. I thank you guys for sharing that for sure. Sounds like you have a great internist too. Yes.
I have a friend who has been diagnosed with Alzheimer's. He was put on medication
Yeah.
to slow the process.
Sure.
He's now at the strongest level.
Dose of it?
Is this a common thing that they do, or are just some people are not qualified to be on that? Or
Sure.
are they on the other one? When does that?
Yeah, that's a great question. So the question's about medication. It sounds like they've been increased to what you understand is the highest
As far
dose.
as he can go.
As far as he can go. So I'll go back to this preparing for the visit and what the assessment looks like. I don't want to skip too far. Well, you know what, I'm gonna hold that before I get right to the end. We're going to talk a little bit about medication, and I'll remember that one about, when there's an ability beyond them, if there's side effects, there's a number of things that contribute to an ability to take some of the medications that are used for Alzheimer's disease, other forms of dementia too. It's a good question. So when selecting a doctor, I think we've talked about this a little bit, can diagnose the disease with greater accuracy. So we talked about this a little bit, Valerie, good question before. We'll talk about that in the next slide when we're reviewing what some of the diagnostic, what the process is a little bit. That'll get at how they're getting closer to being more and more definitive with diagnoses. Starting with a physician who has experience in diagnosing Alzheimer's disease. I think great example that sometimes that is your primary care doctor or an internist who has that experience. Other times you may need to, or the primary care may additionally refer to a neurologist, neuropsychologist. Sometimes they do that pen and paper testing that's much more extensive, can be up to 3 hours sometimes. That's kind of their specialization. But I think the key is that you want to make sure if you're consulting with primary care or a specialist that they have experience in diagnosing and treating, working with individuals with Alzheimer's disease or other forms of dementia. That kind of level of experience is really important when you're looking at this more thorough diagnostic evaluation or steps in the assessment here.
Can you just ask your doctor?
Sure, you can ask your doctor too. Yeah, do you have any experience in this?
No, you can say that to your primary.
Sure, oh yeah,
You have
yeah.
it.
Do you have any
And they'll say you
experience?
have it, right?
Yeah, and then they'll say, yes, I do. No, I'm just kidding. I think it's important to ask. It's a really important question to ask. Do you have any experience in diagnosing Alzheimer's disease or other forms of dementia? That might be a follow-up question to, this is normal aging, you know, in a kind way, but do you have any experience with this? I'd really love to get, I'm concerned about this, and these are the reasons why, and I'd like a further evaluation. And again, we can talk you through that. We can have a dialogue about what that might really look like with your doctor if that's helpful. The steps to the assessment, so we talked a little bit about medical history. As we talked about earlier, that can be really important in terms of ruling out, is it a dietary situation, nutrition imbalance, something like that that's going on that's either the cause or contributing to the symptoms. Mental status evaluation, that's also looking at your attention to time and place. So they might want to check, is this something that's acute, that's going on? Do you know where you are, what time it is? Is it something that might be more acutely off in terms of your cognition? That's what they may be getting at there. And then there's a series of evaluations that test your memory, reasoning, and thinking. Sometimes that's called a neuropsychological exam. It can be done with a neurologist or a neuropsychologist. A bit more pen to paper testing. And there they're trying to tease out where are some of the symptoms that they're seeing, where might that correlate to changes in the brain, so that they can try to get at what form of dementia may be causing the symptoms, if any. They're also now looking at a bit more of, I think it's on here, yeah, brain scan. So it might be used to rule out stroke, but there's also been advances in brain scans as well to be able to see a bit more. MRI would show those structural changes. Are there structural changes to the brain? PET scans and more advanced PET scans may be able to pick up, are there abnormal proteins or other changes in the brain that are harder, that you can't see on MRI, but you can see on a PET scan. So with all of this kind of combination of assessment, and advances in technology with scans, they're getting at, as close as there's different sides of the camp. Some doctors and scientists are still saying really and truly the only definitive way is on autopsy, and others are saying with these advancements in PET scans, we can really see plaques and tangles and other hallmarks associated with the disease that would say definitively that's what's going on. There's some different camps, if you will, in terms of that, but with this extensive, assessment process, it can be very close to and often say probable, if not more definitive, what may be going on. A piece I skipped over, I just want to talk about, we've mentioned this a little bit, but preparing for the doctor's visit. This may be for this more thorough diagnostic evaluation or even talking to your primary care. What can you do to expand upon what your doctor is going to see in the moment in time in the doctor's office? So that might be a log of the times you've maybe noticed changes, or a loved one might be recording. You could ask them to help you in recording some of the changes that you're seeing. All medications, including over-the-counter or herbal, are important to bring as well. Could be a medication interaction that's going on that's contributing to or causing the symptoms that you're seeing. List of current and previous health problems are also important, just to give this full medical history about what's going on. And some of these things, again, you can kind of do to prepare before you go to an appointment. I think the piece here that's important to talk about, and we touched on this a little bit, but it's really important to know that when the diagnosis of Alzheimer's disease or another form of dementia, there can be a lot of emotions associated with that for a person living with the disease, family members and loved ones, and all these emotions and many more are all okay. They're all normal, they happen. I think there can be some grief associated with what's going on and some loss in independence or ability. Sometimes people that are living with the disease have shared that there's some relief or acceptance if the diagnostic process has been long or they've been noticing symptoms for a long time and unsure what it is. There can be some relief that's felt in knowing what the diagnosis is. Can provide some of that feedback too. I think it's just important to know that any and all of these emotions are okay and understandable, and important just to acknowledge them too. We talk about with Alzheimer's disease, going back to this idea that it's progressive, so the symptoms progress over time. At the Alzheimer's Association, we typically talk about early, mid, and late stage, but it's important to know that there are a range of individual differences within every person. So similarly, there's a range of individual differences when someone has Alzheimer's disease. We didn't capture this, but it's triggering me to remember Joyce, whose clip we couldn't hear in the beginning. She shared that one of the early symptoms she noticed were changes in her walking, so in her gait. She was having trouble tripping, having more falls. And we typically don't see that with Alzheimer's disease, changes in mobility often happen later on in the disease when that part of the brain that controls our motor function is impacted, but she was having those symptoms earlier on. So I think it's just an important highlight to note. You may see changes, you may see symptoms that fit kind of neatly here, but again, this idea of things being linear is not usually how life is, right? We're all human beings. There's a number of other medical conditions potentially going on, environmental and other factors that may be contributing too. So the stages can help give you a sense of what's going on, but we try not to stick too closely to them, but just to give you a sense of what some of the symptoms may look like over time. Any questions about that? Any questions so far? We can't hear from Monica Parker, but she's going to talk a little bit about the importance of planning early. So whether it's you're noticing symptoms or mild symptoms and you seek out a diagnosis, how important that can be, or you have a very wonderful doctor who's seen you over time and picks up on things early, how essential that can be for care planning, being involved in your care planning if you're living with the disease, and also seeking out treatments or maybe getting involved in clinical trials, which a lot of people find impactful and important to do as well. Growing your support system and educating yourself about the disease. There's a number of reasons why, but we do know that planning early can be really important for everyone, for a person living with, for sure. Having that sense of involvement and being engaged in the care planning process is really important, can be essential. Medication. So great question before. We'll talk about that a little bit more here. So there are a few medications that are used for the treatment of Alzheimer's disease. We
Yeah.
do know that there are
Someone can
not
remember
currently any medications that change the trajectory
Remember.
in terms of
That is
stopping the
Memento.
disease from progressing. One doctor that is on our medical and science committee has described some of these medications and their ability to lift the fog, so they might lessen the impact of some of the symptoms for a period of time, but at some point, the medications do not continue to work. They won't stop the disease from progressing at this point. That's what we do know. Any of these medications. And some of them do have a maximum dosage that you can go up to, either for tolerance related to the individual and side effects, or in combination with other medications, and just there are max doses with medications in terms of how high up the dose they
I
can
just
go.
wonder why they put them on this, it's just prolonging it, it's just prolonging it, it seems, inevitable.
Yeah, I hear
totally
you.
understand.
Yeah, the question is why you might take the medication. And I think some people see more of an impact than others in terms of that lifting of the fog, if you will. For some people, even a year or two of lessening of symptoms or lifting the fog, it can be really important and helpful. The disease will continue to progress, but some people do see a lessening of symptoms, and that can be really important, even if it's not,
Yeah, the short term is just about gone, but I mean, and long term, my gosh, you can show you,
Sure.
it's amazing.
Yeah.
It's amazing.
Mhm.
But we've seen a slight, change, and it was mentioned, what about, I mean, is this something, if they're on this, is it something they can be taken off, or is that illegal? Would that become a legal thing if you wanted to say, taken off?
Stop a medication? So stopping great question. Stopping a medication, usually in combination of consulting with a doctor about that. A healthcare proxy might be able to do that if the person can't decide for themselves if they want to stop the medication. Not the same in terms of, my understanding, this category of medications are not the same in terms of other medications that do require some legal consultation and things like that in order to
Yeah, I
stop.
was just wondering, I did that myself, and,
Mm-hmm.
and they were just, I mean, it was a question that came up, is this something that can legally be done, or are they weaned off it, or what would be their reasoning to want to do that?
Yeah.
Other than let it progress on, and,
Yeah.
it's a hard call.
It's a very hard
I mean, I'm
call.
not family, so
But you're seeing it,
I'm
you're
a close
witnessing
friend,
this.
and I just think,
Yeah.
I don't know, I don't understand.
Mm-hmm.
It's fine, I mean, other than, short, he couldn't tell
Yeah.
you minute to minute, but boy, he'll tell you everything about his life in Ireland before he came here,
Yeah.
right down, it's amazing. It's been quite a journey to see him
See it.
do this, but, the medication, it just came up in conversation.
Mm-hmm.
Can you stop it, why would you, and is there a weaning off process?
Yeah.
Or I'm assuming you don't stop it like
It's
that.
a good question, yeah. Great questions about, and thank you for sharing that.
Kind
And
of
it's-
send him into a tailspin type of thing, I don't know.
It can. I think that's why with just these medications, just like other medications, you really want to have a conversation with a doctor about stopping, weaning off, continuing on. Sometimes people it's a very individual decision, just like other medications are as well. If you're not seeing any negative side effects, you aren't sure how much of a positive effect you're seeing, some people decide to continue. Other people say, it's not worth being on, so we want to stop and wean off. My understanding would be you'd want to talk to your doctor about weaning if possible versus just stopping. But again, conversation to have with the doctor, for
Physically,
sure.
he's good as a fiddle, and
Mhm.
he's okay to scream, and we know. But I've just had that question,
It's
my
a good-
own FYI.
Yeah, no, it's a good question.
Yeah.
I think some of it plays into it too is sometimes, if he's not taking any other medications and it's difficult to take these medications, he's not wanting to, sometimes that, other things play into it other than just starting and stopping, I think, too. It's a good question.
A couple of other things, Tom, but I think one's warfarin,
Mm-hmm.
the other one, I think might be blood pressure, I don't know, but
Yeah.
really, he goes all the time, yeah, but it is, progressing, but,
Progressing.
I just wanted to know, since the subject, I never even thought about it.
Just came up, yeah.
Yeah,
It's a good question.
because it can be very difficult to tell, that, maybe this medication isn't what we want it to be on.
It's like a lot of things in terms of treatment and interventions. It's with for Alzheimer's disease, other forms of dementia, other medical conditions too, weighing some of the cost and benefit for an individual. Again, we know this, and it's important to highlight, we know if everyone has individual differences with or without Alzheimer's disease, other medical conditions, so many factors that play into it. So it's hard to make global statements.
Is it something they wanna do just so that he will, so to speak, cross over and then just be at peace with himself, or, I don't know,
Hard to say maybe why they're, yeah, I wouldn't, yeah. But some people also, there's sometimes a combination of medications used in combination, so Aricept and Namenda are sometimes prescribed together too. It's just a combination of the medications that have been put together too. And some people see some positive effect from that as well. This is a big area of research, obviously, in terms of more medications for prevention, hopefully intervening to continue to slow or hopefully stop the disease. So this is an area of growing research, and a lot of people living with the disease have found that being involved in research studies that are looking at some of these medications can be an impactful way to be involved, just as individual a choice as deciding to or not to take medication. So it's a hard choice.
It might not be a hard choice for
Yeah,
family, I'm sure.
hard choice, very difficult.
So what can we expect from these drugs?
Well, this is what,
Primarily, we can expect that they may improve your learning and memory a little bit. They may improve your word finding abilities.
so Dr. Peterson is just,
Could you make it louder?
She can't, Mom. She already.
so he's sharing what we just talked about. You may see some slight changes or improvement, lifting the fog in some memory and thinking, but not indefinitely, just for a period of time. So that's what we're seeing with some of those medications now. Yes, question?
They experimented in medical marijuana.
Medical marijuana. That is a growing area of research. That and other complementary therapies, if you will. Not that I've seen in terms of research that's definitive.
Pain and discomfort.
Pain and discomfort. I have heard that there's research related to that, to medical marijuana use. I think there's been some studies with that, most robustly related to cancer and other medical diagnoses in terms of pain. But that's an area of growing research too. Nothing definitive in terms of that being a treatment or alleviating symptoms of Alzheimer's disease, but there's research there, so time may,
Is that because they have been legalized?
time may tell. That may be a contributing factor, yeah, in terms of where they can do the study. Yeah, it's a good point. It's a good question. So clinical studies, I mentioned that. Another piece that's just important to highlight, it's a very individual decision to participate in a study. There's a number of reasons why people may. Sometimes, the sense that it's fueling towards treatment options is encouraging. Other times it can allow access to more advanced PET scans, for example, that aren't currently covered by insurance or other interventions. I think it's important if thinking about clinical studies is of interest, just to explore it a bit more. They're not all related to medication. Some are related to the lifestyle interventions like diet that you mentioned before. Some studies are looking at things like that, as well as scans and diagnosing early. So it's not just medication related, although those are a fair amount of research studies too. And another component that it's important that we want to make sure that we're a part of anyone's support network, their team, is the Alzheimer's Association. So we offer a number of programs, of supports, all at no cost to families. So we have our 24/7 helpline that you can call, just like the name says, 24/7. A live person will answer the phone and can talk with you about any concerns that you may be having, a question, something you read in the paper that was a new treatment or a new cause that you have a question about. You can call us anytime. Or if there's questions that come up when you're diving through this information that you're leaving with today and it spurs on another question, you can call anytime. We also set up individualized care consultations, so they're one-on-one conversations with a care consultant to dive into things a little bit more. We can set them up, conference call with family members. We typically do them by phone. We do them in person at our regional offices, but phone tends to be the most convenient since we're not always right as close by as we wish we could be. But that's a way to get some more individualized one-on-one support, again at no cost. We have education programs like this one in person and online, support groups, and our website is a wealth of information. It has details about the diagnostic process, steps to diagnosis, more information about Alzheimer's disease or those more rare forms of disease as well. So there's a lot on there. And sometimes people call our helpline because they're on the website and there's so much information that it's hard to parse out which page to go to, so we can help you navigate the website as well, if that's helpful. I know we covered a lot of information today, but I hope that it provided you with a bit more about memory changes, Alzheimer's disease, and other forms of dementia. I'm really grateful for all your time today, and I'm happy if there's any questions within the group or if you have questions one-on-one, I'm happy to answer those before. Yeah,
People who have Alzheimer's at the worst stage.
Later
I don't know what
stage?
the number
Yeah.
is, 4, whatever. Why are they violent?
so sometimes the question was about more aggressive or violent behavior that can sometimes accompany Alzheimer's disease and other forms of dementia as the disease progresses. So it depends. As the disease progresses, it can impact different parts of the brain, including that frontal lobe. So it might change the ability to process or have insight into a behavior, maybe being a bit more of a reaction or aggressive than you might have responded with otherwise. Sometimes too, with the brain changes that can happen, there can be a misinterpretation of the environment. So there's visual changes that can happen as well. So you might see a reflection and think it's someone trying to get into your home and have a reaction to that. It might be more aggressive than you might sense in that interaction, but to the person that's seeing someone trying to break in their home, that's a somewhat normal reaction. So there's a number of things that can kind of play into what might be a more aggressive behavior that might be going on, both brain change-wise and interpretation of some of those changes.
Maybe
If that makes
somebody
sense.
that was very mild,
Mhm.
very sweet, never swore,
Yeah.
all of that. When they get to that, I don't know if it's the final stage, but, up there,
Mm-hmm.
they're very violent, and they're strong.
Mhm.
I mean, they could fight like the nurses are,
Yeah.
and climb up against the wall.
Yeah.
And you're like, wow, where did this come from?
Well, there can be, yeah, and I think to your point with their friend that has no other, I think there's a number of variables at play, right? Other medical conditions or lack thereof. So someone may be very physically strong and they have a lot of changes in their thinking that are causing more aggressive, either verbal or physical behavior
Yeah.
too.
Yeah.
It's
So,
very
yeah.
interesting that I learned about sundowning,
Mm-hmm,
which
mm-hmm.
I know when I first experienced it with this person, but, oh, what is this?
Yeah.
It was, would you explain that more? I mean, maybe some
Sure.
people aware of it. some
Yeah,
aren't.
anyone aware of or heard of sundowning?
Yes, amazing.
Yeah. There's a number of things that can play into that, typically seeing a change or worsening of symptoms later in the day. A number of things that can contribute to that. It's typically not just one thing, but again, we're thinking about that, some visual or perception changes too. As the day gets later, there can be changes in
When I
shadows
would be
and,
leaving after a visit, I would be leaving and all of a sudden this
yeah.
is gone.
As the day wears on, it can be very taxing to get through or compensate through the day, and sometimes we see a deterioration in that way.
Changing maybe, I don't know. It's
Yeah.
just- It kind of threw me the first time it happened, but then it was explained to me, that the day is getting darker, they don't understand why it's happening, but they're afraid, they don't know what's
Mhm.
going on, but it was a very interesting term, sundowning.
Yeah, yes, can be a common phenomenon or symptoms that you see. And something too that we talk about on the helpline a lot, are there ways to make the symptoms of that lessen environmentally, keeping the room well lit, trying to, mimic less of that dusk kind of look in the home. Sometimes it may be that there's not a lot of activity or routine going on throughout the day and looking for more to do as well. So can be very individual as much as it is a common phenomenon too. So something else we can kind of dive into with people individually. Yes.
I noticed there's a correlation between Down syndrome.
Yes.
Now, is there one with autism?
That's a great question. Not that I'm aware of, but it's a good question. That would be a great one for my colleagues on our helpline. Yeah. Maybe more information to come in terms of autism and a correlation or other diseases in correlation as they're doing more and more studies kind of earlier on with people as well.
Because I see, and we have an autistic granddaughter,
Mm-hmm.
and I see similarities
Interesting.
between her symptoms,
Mm-hmm.
if you want to use that word.
Sure.
And the either
too that there are other disease processes that cause changes in memory and thinking, right? So you may see that related to autism. You may see that related to Down syndrome too. But is it the two separate diseases, or is it the symptoms that might be similar?
True.
Yeah, I think I haven't heard that, but there may be research on that that I'm not aware of. It's a really good question. Thank you. Yes, Valerie.
I've got a comment rather than a question.
Okay, comment.
My sister lives in Wales.
In Wales.
Yes.
That's where your lovely accent is from.
That's where it comes from. Her husband has dementia.
Yep.
One of the big problems she has is he doesn't want anybody to know he has dementia.
Yeah.
And he is mad as hell that my husband and I found out through our niece. Our niece told my daughter, and my daughter told us when she came to visit him in America. And he was really upset.
Yeah.
And my sisters cannot talk to me on the phone and tell me the truth of what's going on, because he's listening in on everything.
Okay.
Very controlling
Yeah.
that way. And she says she's in charge of the X-ray department of the local hospital. The only respite she gets is when she goes to work. And then he's calling her every 15 minutes on her cell phone to ask her why isn't she home with him. And it's,
Yeah.
I really feel for her.
Yeah, for both of them. Yeah. Thank you for sharing that. Valerie was just sharing about her family story,
Yeah.
experience with
I think-
Alzheimer's disease.
So it's a disease that not only affects the person, but affects everybody around.
Sure, like most,
Yes.
many diseases,
Yes,
right? And I
that's
think
true.
it's true, yes. It's important to support, that's why I think this idea of support and education can't be overemphasized, how essential that can be. And sometimes that's building your care team with your doctor, friends and family. We at the Alzheimer's Association want to be a part of that, but you want to?
When I first got diagnosed,
Question there, you can.
and then I talked to somebody on the helpline, I said, no, you really need to tell people around, plus when you say it out loud, you kind of get excited.
Yeah, name entertainment.
So I told people, and the stigma they have on Alzheimer's is very sad, because they perceive a certain look to Alzheimer's. And I've had a couple of people say to me, I don't believe you have Alzheimer's, because you talk fine, or you remember things, or you're this, or you're that. I says, trust me, if I didn't have that, I wouldn't make this up. And it's frustrating that I have to justify myself.
Sure.
And my sister won't talk to me, she hasn't talked to me in 2 years. She didn't like the gamut of emotions I had when I first got diagnosed. She didn't handle the roller coaster ride I was on, so she's not talking to me. So if there is different reactions, just because you see one Alzheimer's person, that's what everybody else is like.
You've seen one person with Alzheimer's disease. If you've met one person, just like if you've met one person, you've met one person.
That's
Yes.
it, everybody goes through it differently.
Thank you for
But it's
sharing
very
that.
embarrassing. And
I know he's.
but I have to say it sometimes to get over the embarrassment.
Thank you for sharing that. Thank you for being here. I appreciate you all being here. Thank you so much. Yes.
My mom passed away from Alzheimer's, and towards the end, one
Yep.
of the things she lost was the ability to swallow.
Sure. Yep.
So that's,
That can happen. Yep. So as the disease progresses, we saw that picture of the brain before. It can impact all parts of the brain. So it starts in one area but can impact all parts. And that's there. Ultimately, it can impact parts of the brain that control our ability to swallow and breathing, other areas as well. So that can happen. Yeah. Thank you for sharing that. Good question. Thank you all. I appreciate your time. If you don't mind filling out the survey, that would be really helpful for me to know. Were there things that you were hoping I would cover that I didn't? Constructive feedback, anything like that. There's a folder up here that you can just slide those in, or you can leave them at the table and I'll collect them afterwards. So thank you so much.